Thank you, Jesse. It won't surprise anyone. I'm going to recommend an approach that's derived directly from the NIH trial of tidal volume reduction in ARDS. Many people, when I say do it this way, say, well, that protocol was too complicated, so many rules, and it's not conducive to individual patients. What I hope to convince you is that it is a practical approach that already incorporated in the protocol rules are ways to accommodate management to individual patients. So I carry a tape measure in my coat pocket, and I measure the height of my patients because lung volumes are set according to gender and height. The patient's height and you know the gender, which of course is easy, then you can customize tidal volume to individual patients. So maybe you think you can estimate patients' heights accurately. You're probably right, but if you carry a tape measure and use it, it's the beginning of a rigorous approach, and I think it sets a good example. These are the equations for calculating what we call predicted body weight, which I think is simply a lean body weight. They're easy to use. The two equations, females are, these of course use the classic meters. Either one will work. Here's an example of how to do this. 5 feet 11 inches or 180 centimeters tall. That's my height. Predicted body weight according to the equation comes out to 75 kilograms. We use the volume assist control mode, and I use it if somebody insists that pressure control is a technique they're more familiar with and just seems to make more sense. I would say that's okay, but you have to pay careful attention to the tidal volume that's moving back and forth and adjust the PC level, aiming for the tidal volume that we should. So the initial tidal volume should be ml per kilogram. If the tidal before starting this procedure exceeds this level. For me, it would be 600 milliliters. After 2 hours, reduced to 525, 7 ml per kilogram, and after 4 hours from beginning, make a subsequent adjustment down to 6 milliliters per kilogram. Subsequent tidal volume adjustments are made according to plateau pressures. We measure plateau pressures every 4 hours, and after each change in tidal volume, or PEEP, we measure the plateau pressure with a 0.5 respiratory pause. This is practical to do. Wait for a longer period of pause, a second or more, especially in patients with a respiratory rate. You won't get an accurate measurement of plateau pressure. We reduce tidal volume to 5 or 4 ml per kilogram only if necessary to stay below a plateau pressure goal of 30 centimeters of water. But then the plateau pressure is improving, there's an opportunity to volume back up towards 6 ml per kilogram. Some patients become severely reduced tidal volume, and when this occurs, we volume to 7 or 8 ml per kilogram as long as the plateau was a rule that we used during the trial. We used it in approximately 20% of instances. It are difficult to manage when they become so dyspneic, and we utilize this rule sometimes in my clinical practice. Adjusted to maintain a minute ventilation when we lower the tidal volume, we would raise respiratory rate in a reciprocal fashion. If we make the initial tidal volume adjustment, we would make subsequent ventilator rate settings to achieve that pH goal as shown here. And FiO2 are as shown according to this PEEP FiO2 scheme. A scheme that was developed by consensus in 1990, 20 ARDS network investigators. Many people in our network said, "This, I think I can use it," and my colleagues adhered to it. And it was a practical approach, supported over 90% of them. with respect to arterial oxygenation. The ratio was set in a traditional range of ventilation. We used any Inspire this goal. We managed goal is 7.3 to 7.45. If the pH was below 7.3, the rate up to a maximum of 35. 35 and the pH still below, administration was allowed. Clinician's judgment call. And the pH was below this level, 7.1 increase. It's not required, but again, it's a clinical. We would begin weaning in any patient if the PEEP level. The technique we used was by, but I don't have a strong feeling that you have to use pressure. Familiar and your intensive care unit favors an alternative approach. I think to try it if the gas exchange is, and to use a method that moves the patient along expeditiously towards spontaneous breathing if at all possible. What I've summarized here is available at this website. Synopsis, something I'd like to this set of protocol rules in our trial 100% of the time. There were occasions when clinicians felt strongly that they needed to deviate from the protocol rules. What we strongly encouraged while we were doing the trial and what we encourage now is that you have a good reason to deviate from the protocol rules. Thank you very much.